Yes, now it's my pleasure to introduce our first keynote talk by Dr. Susan Etheridge, a pediatric electrophysiologist from Primary Children's Medical Center and the University of Utah. As Alice just said, she's also the vice president of our SADS Board of Trustees. She'll be speaking on personalized medicine in the treatment of SADS conditions, from drugs to denervation to devices. And a reminder to our families to post any of your questions. We have 7 already posted in advance, but please add questions as you listen to Susan's talk, and we'll address those following her talk. So welcome, Susan.
Thank you. I'm going to share my screen. So thank you very much to the SADS Foundation and all of the workers at SADS. I am the vice president of the SADS Foundation and have been for, seems like forever. And I'm pleased to be able to talk about personalized medicine. What is personalized medicine, or let's call it precision medicine? It's combining an individual's their genomic profile with clinical information that will help guide diagnosis, therapy, and intervention. So put simply, providing the right treatment to the right patient at the right dose and at the right time. This is not precision medicine. Pharmacogenomics are probably the lowest hanging fruit, the most practical application of precision medicine today. The phenotypic variation in metabolism and response to certain drugs is pharmacogenomics. It can help us predict therapeutic outcomes, dose, response, or toxicity. And based on your pharmacogenomics, variations can range from a complete lack of drug therapeutic efficacy to serious, potentially life-threatening adverse drug reactions. So again, this will help us provide the right treatment to the right patient at the right dose and at the right time. We're not very far along with pharmacogenomics yet, but there are some data about pharmacogenomics and beta blockers. We have in our bodies genetic polymorphisms, little genetic changes that contribute to the variability in our responses to drugs. Some of the beta blockers have been studied, and some of them are substrates for cytochrome P450 2D enzyme metabolism. These are the beta blockers that probably do have this and are substrates for the cytochrome P450. This CYP2D6 gene is a highly polymorphic. It's varied among the population, but not all beta blockers are actually metabolized through this. And in fact, atenolol, which we don't use very often, but nadolol, which we do, are not really susceptible to this. Metoprolol is probably the most studied. And interestingly, despite all the study, at present, we don't think that one's polymorphism in CYP2D6 influences either efficacy or toxicity of this drug. So despite the availability of us to clinically genotype patients for this, data would suggest that at present, this is of little benefit. There are additional data with this ADRB1 gene, especially this arginine 389 phenotype or genotype, and it has been associated with better response to beta blockers, including a better hypertension response, heart failure tolerability, and glaucoma. But not all studies looking at this have been positive, but some have. And it might actually be a starting point from which beta blocker therapy might be individualized in the future, but probably, given the evidence of pharmacogenomic interactions between beta blockers and certain polymorphisms, likely we'll be looking at combining multiple risk alleles that may be informative in managing our beta blocker therapy. So hold tight. The reason you might not be responsive or as responsive as someone else to beta blockers may have a genetic background. I'm going to speak largely about inherited arrhythmias, and I've listed some, and in dark are the ones that I'm going to speak the most about, the ones I know the most about. Inherited arrhythmias are genetic diseases. They can result in sudden death in the young. Typically, they do this by interfering with ion channels. Ion channels, there's a well-orchestrated activity of a diverse number of ion channels. They mediate what we call the action potential. It's like a little ECG from a cardiac cell. If you alter the function or expression, it can disrupt the action potential, causing abnormal electrical activity of the heart and arrhythmias that can, in fact, result in sudden death. Many, maybe most, SADS patients are well covered by traditional therapies, drugs, denervation, or devices. But some are not. There are patients where we see beta blocker noncompliance or intolerance. There are breakthrough events in some patients despite maximal therapy. Some diseases are almost always problematic to treat: Jervell-Lang-Nielsen, the CALM mutations, and Timothy syndrome. And many CPVT patients are quite challenging. I certainly take care of patients who, if they miss one single dose of their medication, a beta blocker, flecainide, et cetera, they put themselves at risk and actually do have events. And some diseases have pretty poor medication options, such as Brugada syndrome. Let's start first thinking about catecholaminergic polymorphic ventricular tachycardia. This is an ECG from my very first CPVT patient, a 6-year-old who had a cardiac arrest while chasing her dog. I don't think anybody in the world would look at this and think it was normal, but what I see is bidirectional ventricular ectopy and tachycardia. This is a rare disease, but a potentially lethal genetic arrhythmia syndrome. It causes exercise or stress-induced arrhythmias. The classic ECG finding, and one that's fairly rare, except with CPVT, is bidirectional ventricular tachycardia, or this 180-degree change in your QRS rotation. Interestingly, most of these patients have completely normal hearts. They're young, healthy people. So when they have their bidirectional ventricular tachycardia, they often tolerate it quite well. Unfortunately, though, it can quickly degenerate into a rhythm that no one tolerates well, ventricular fibrillation, as shown on this screen. This is a disease that has an early symptom onset. We don't really know about fetal or SIDS, but the average age of presentation is between 6 and 10 years of age. 80% of patients will be symptomatic by 40, and sudden death can occur even in older adults. There's a 30% mortality if a patient is untreated by age 40. And this is a disease where patients require lifelong therapy, and it has a higher symptom burden than many of the other channelopathies we'll talk about. Because it's a disease of young people, we need to think about this and screen early in patients, in family members of affected patients. We can genetically screen when there's a genetic target that exists, but we do recommend pre-symptomatic treatment since sudden death can be the first symptom. And this is a highly penetrant disease. You'll see in other diseases, long QT syndrome, Brugada syndrome, these are not as penetrant. What penetrance means is that if you carry the gene, it's likely that you will have symptoms. These patients classically have what's called a normal electrocardiogram, but a close look at many of these patients suggests that it's not classically normal, that it's bradycardic, and these patients may have a fairly prominent U wave. The diagnostic test separate from genetic testing, so the clinical diagnostic test that's helpful in this population is exercise testing. And there is a very interesting thing about exercise testing in CPVT. Patients will have an arrhythmia onset at a very reproducible and patient-specific heart rate when untreated. Atrial arrhythmias can show up during exercise testing or clinically, and often happen during exercise testing before the ventricular arrhythmias occur. And the ventricular arrhythmias are PVCs, bidirectional or polymorphic ventricular tachycardia, or ventricular fibrillation. This is the ryanodine multiplex, and these are the genes that are known to be associated with CPVT and the percentages of patients that carry these abnormalities. You can see CPVT1 or ryanodine receptor 2 variants are the most common cause, but 35 to 45% of patients remain genetically elusive. Most of the mutations or the variants that happen do affect the ryanodine receptor. So I'm going to talk a lot about the ryanodine receptor. It's a pretty interesting little thing. It's a large ion channel that sits on the membrane, not the cell membrane, but the sarcoplasmic reticulum membrane within the cell. Genes in our body encode for proteins of this channel, and these 4 proteins must come together to make this structure, which looks a bit like a donut with a hole in the middle for calcium to leave. Mutations or variants result in changes in the proteins, and it makes it such that this channel can't stay closed. So calcium leaks out. It actually leaks out in diastole, and probably the amount of calcium that leaks out controls the amount of arrhythmia. Now, the cell doesn't love that calcium, so it tries to spit it out. And what it does is it exchanges it for sodium. Sodium depolarizes the cell and create these delayed after depolarizations that, when added to stress, emotion, exercise, can create the signature arrhythmia of bidirectional ventricular tachycardia or other arrhythmias associated with CPVT. Keep sodium in mind because it will become important when we're considering therapy. Beta blockers still remain the first line of therapy for CPVT, and nadolol is our preferred drug. We use the highest tolerable dose, most at about 1 milligram per kilogram, but some at a higher dose. We evaluate the efficacy and compliance regularly by exercise testing or Holter monitoring. And I've used Holter in patients who have completely normal exercise tests because we're not picking up their precipitating event. I have had patients where certain life experiences cause their arrhythmia. So I'll put a Holter on them and ask them once they're on therapy to do that life experience. Also, there are patients who are either too young or have a disability that prevent them from performing an exercise test, so a Holter can be useful. Like in long QT syndrome, as we'll talk about, not all beta blockers are equal in CPVT. And we think nadolol is superior. It causes more bradycardia. It lowers the maximal heart rate compared to other beta-1 selective beta blockers. It's generally once a day dosing in older children, young adults, and adults. So that provides better compliance. It's easier to remember to take a drug once a day. Data from Laren here are shown, which compare the arrhythmia burden on patients before any treatment with beta blocker at all, and anything besides green is bad, red being ventricular tachycardia, orange couplets, and yellow ectopy or PVCs. You can see beta-1 selective beta blockers are almost as inefficient as taking nothing whatsoever, but once you add nadolol, there's more patients in the green box and fewer arrhythmias associated with their disease. There are a group of patients where their disease is such that beta blockers are not enough. They have events despite their beta blocker therapy, or they fail to suppress their arrhythmias on Holter or exercise testing, or they just struggle with non-compliance or intolerance. Flecainide has really proven to be efficacious in this disease. It's a class 1C antiarrhythmic agent, which means it's a sodium channel blocking agent, proven effective in ryanodine, CASQ2, and gene-negative CPVT, and suppresses delayed after depolarizations. We've known for a long time that it can directly target the underlying arrhythmia mechanisms and provide direct channel blockade, so direct release of calcium from the sarcoplasmic reticulum in a CPVT mouse model. We also know that flecainide suppresses triggered beats via its sodium channel blocking effects. And these were very early data looking at a couple of patients with CPVT. This first patient is a 12-year-old who had an uncommon type, a CASQ2 mutation, who is here on a conventional therapy that at that time included a beta blocker and a calcium channel blocker. We no longer consider calcium channel blockers therapy. You can see his arrhythmia on ECG, but you can also see on exercise testing his arrhythmia burden. So his time in arrhythmia in purple. And then after the addition of flecainide to beta blocker therapy, you can see the substantial decrease in his arrhythmia burden and a normal ECG. Similarly, these are data from a 36-year-old who had more classic CPVT with a ryanodine receptor mutation, and again, a higher arrhythmia burden when on beta blockers and calcium channel blockers, and then a substantially lower burden when on flecainide, and actually on flecainide alone. There is also the option for left cardiac sympathetic denervation. This is surgical ablation of the lower 2/3 of the stellate ganglion and thoracic ganglion T2 through T4. What this does is it interrupts the source of adrenaline or epinephrine release in the heart. And it can typically be done videoscopically, but you should choose a center where they're very good at this and provide a full procedure. We use this in patients who fail beta blocker therapy and flecainide, or intolerant of beta blockers, or have a significant problem with medication noncompliance. And I sort of think about this as the safety net, especially helpful in teenage boys who are especially problematic at taking their medications. ICDs are something that's certainly in our armamentarium of therapy for the channelopathies, but they're problematic in CPVT. If you look at these data from a research study, you can see that in this pie diagram of all the arrhythmias that received a shock, only about 1/3 of those patients actually probably were asleep or unconscious for the shock or needed the shock. So these 2/3 of patients actually were probably awake when they got a shock. And you can imagine in a disease where pain, stress, adrenaline causes more arrhythmia, a painful shock can certainly be associated with more arrhythmia, and we call that proarrhythmic. And about half of CPVT patients in some studies have appropriate shocks, but you can see almost half have inappropriate shocks, which would be as defined in this pie graph. 1/4 have an electrical storm. That's where you get a shock, you go back into arrhythmia soon after the shock, you get another shock, et cetera, et cetera, et cetera. And obviously that's terrible and painful for the patient and psychologically really difficult. In about 1/3, a shock induced a more malignant arrhythmia. CPVT patients, as we've talked about, are young, and they'll have to have a lifetime exposure to this ICD once it's implanted, and it does have complications. In one study, about 85% of young CPVT patients had ICD-related complications. What about future therapies for CPVT? Dr. Langstrom is going to talk after me, and I think he'll probably address this in a more detailed manner, but I just wanted to mention it. There are a lot of companies, people looking at selective small molecule therapy for CPVT, compounds that stabilize the Cas-Q2 polymers and target calcium release, inhibitors of ryanodine-mediated calcium release. There are people actually looking at with cryo-electron microscopy, this complex ryanodine receptor, and identifying in its structure druggable pockets for future drug-based design. There are people that are looking at sinus node dysfunction and treating that. Sinus node dysfunction is a characteristic of CPVT. And if maybe we can raise the heart rate, we can decrease the arrhythmia burden. And there are CPVT mouse models of adeno-associated viral vectors that deliver various calcium handling proteins. So selective small molecule inhibitors of ryanodine-mediated calcium release may in the future provide better tolerated and more effective CPVT therapy. Data have looked at dantrolene, which is a medication that we use for muscle disease, and it resulted in decreased exercise-induced ventricular arrhythmias in some CPVT patients. There's this unnatural verticlide, an unnatural enantiomer, the word I never can pronounce, of a natural byproduct that's selective for ryanodine with an antiarrhythmic efficacy in vivo. There's calcium calmodulin-dependent protein kinase 2 inhibition with either a KN93 molecule or an adenovirus-mediated delivery of a calmodulin peptide inhibitor that suppress arrhythmias in mouse models of CPVT. And finally, this drug, cefuzine, is an inhibitor of mannose and has been used to successfully rescue expression of calsequestrin and reduce CPVT occurrence in a triadin knockout mouse model. So I think we're looking at researchers and drug companies to provide us with maybe better, more definitive therapy for CPVT in the future. Switching gears and talking about Brugada syndrome. This is less common than long QT syndrome, but probably more common than CPVT, occurring in 1 in 2,000 to 5,000 people with a definite male predominance. Symptoms include syncope, seizures, agonal breathing at nighttime, and usually appear in adulthood. This is typically a disease of adults, but not uniformly. The mean age of onset is 41 years of age. And there is recent debate about whether this is in fact a channelopathy or a cardiomyopathy or something that is in fact both. Although we think of it as a disease of adults, in the original paper by the Brugada brothers, before it actually had a name, there were 8 patients, and 3 of these were children, 2 siblings who had had their first episode of aborted sudden death at age 2 years. Oops, sorry, I don't know why that went away. The genetics of Brugada syndrome are complicated. Certainly, there are known mutations in SCN5A, the sodium channel, that cause disease, but 20 other genes have been identified as problematic. There are, in that population of the 20 other genes, a lack of sound segregation data, meaning have the gene, have the disease. And these non-sodium channel rare variants are probably fairly prevalent in healthy subjects. So at present, we really only think SCN5A, or the sodium channel, remains the undisputed disease-causing gene. So what about the rest? Because it really only represents about 25 to 30% of the population. So what about the other 75% or 70%? Well, they remain genetically elusive, probably because we're looking at one gene, and this is maybe a disease that actually is polygenic. I'm going to talk a little bit about that. Oh, sorry. So if you think about, in some families, Brugada syndrome may be near monogenic, sodium channel families. In fact, you have the gene, you have the disease, but only this sodium channel should be used for family screening. In other families, the remaining cases may be explained by oligenic or polygenic model with multiple low frequency susceptible variants, most of which have yet to be described. There are also hormonal and environmental factors that affect this disease. Events typically occur during times of increased vagal tone, like sleep, during bradycardia, and interestingly, during fever or anything that increases your body's core temperature. There are hormonal influences. This is seen by age and sex-related differences. I find it very fascinating that the male predominance does not occur before age 16 years. And I find it also fascinating that there's a loss of the Brugada syndrome ECG pattern when someone undergoes a surgical castration. So somehow testosterone is affected. And in fact, one can see the development of the Brugada syndrome pattern with the administration of testosterone. This is one of the first Brugada syndrome patients I saw. This is the 3-year-old who had a cardiac arrest at an outside hospital, came to our hospital, and during fever had this abnormal electrocardiogram with the classic type 1 Brugada pattern, specifically noted in V1, 2, and 3. When her fever was under control, that pattern went away completely. So there are pharmacological options for Brugada syndrome, with the idea that with this drug, you rebalance epicardial action potential in the right ventricle and prevent arrhythmias. The typical therapy for classic Brugada syndrome, symptomatic Brugada syndrome right now, is ICD therapy, but it really only addresses the symptoms. It rescues you from the problem. It doesn't prevent the problem. Researchers are looking at different medications to prevent arrhythmias. Certainly in the acute setting in the ICU for storm or a lot of arrhythmias, isoproterenol can be helpful, but it's IV only. Researchers have looked at quinidine, quinine, disopyramide, and phosphodiesterase inhibitors, and interestingly, also Chinese medicine. Now, none of these studies are huge, and definitive therapy remains an ICD unless an ICD is not available or usable in your patient. But a really interesting new idea about Brugada syndrome is that it is a cardiomyopathy. It has a substrate, and that's located in the right ventricular outflow tract. So let's take a patient here who has either an SCN5A variant or a high number of high polygenic risk score. So a lot of other genes that can participate in disease. So this patient has a direct effect on the sodium channel, but also has definitive changes in the right ventricular outflow tract, which are fibrosis, which is our fancy word for scar, inflammation, gap junction abnormalities. So there's an electrical and a structural abnormality that brought together altered depolarization and possibly also repolarization that together affect the right ventricular outflow tract. So here's the heart in an MRI, color-coded MRI. And you can see the right ventricle is in yellow here, and the outflow tract is where all these dots are. This is the left ventricle. And this altered depolarization impairs right ventricular outflow tract conduction reserve. Possibly when you add to that age, gender, hormones, fever, drugs, vagal tone, you develop the Brugada phenotype, either the ECG changes or the arrhythmia, ventricular fibrillation. I think some of the most fascinating data in Brugada syndrome aren't devices, aren't drugs, but is in fact ablation. These are data from Kulawane from Circulation of 2011, where they did mapping and ablation in an epicardial manner. That means outside the heart. They have a catheter that's roaming around in this space between the heart and the sac that contains the heart, the pericardium. And they do mapping of this potentially problematic area, the right ventricular outflow tract. And they found all these fractionated signals. And interestingly, when they ablated those regions, they normalized the electrocardiogram as shown here. This is the electrocardiogram with the classic Brugada pattern before ablation and the normal ECG after ablation, and prevented arrhythmias in this population. Now at present, because this is a complicated procedure that's only done in the hands of real experts, it is still second-line therapy for severe Brugada syndrome patients after an ICD. But I look forward to potentially more data and more experience, and this may be moving forward in its applicability in Brugada syndrome. And so finally, long QT syndrome. This is the most common channelopathy. It's present in 1 in 2,000 people, resulting in syncope, seizures, sudden death or aborted sudden death, drowning or near drowning. Increasingly in my patients, which are children, it's identified in the pre-symptomatic phase of the disease by cascade screening of their family members. This is monogenic disease for the most part. In about 75% of clinically affected patients, we can find a single amino acid change that causes disease. What happens is action potential duration prolongation, which results in QT prolongation. So back to the action potential, again, a little ECG from a single cardiomyocyte, when it's prolonged, can result in QT prolongation. And that can happen due to changes in the sodium channel, too much sodium, so an overly aggressive sodium channel, or blocking one of the potassium channels. Action potential prolongation results in QT prolongation, and if it's prolonged enough, the action potential starts to develop different from delayed early after depolarizations, and these can be proarrhythmic and cause the classic arrhythmia of long QT syndrome, which is called torsade de pointe, or twisting around an axis. Right now, this is sort of the pie graph of what we understand about the genetics of long QT syndrome. Most patients have one of the first 3 types identified, 1, 2, or 3. About 25% remain genetically elusive, and these may end up being a polygenic form of this disease. And I want to just briefly talk about one of the more rare types, because I'm going to mention it later, and that's Timothy syndrome, or long QT8. This is uniquely a disorder of the L-type calcium channel, CACNA1C, and uniquely multi-system disease results. So not just QT prolongation and arrhythmias, but congenital heart disease, syndactyly, which is a curvature of your pinky finger, some facial dysmorphisms, neurologic symptoms, glucose intolerance, etc. In long QT syndrome and CPVT, not all beta blockers are equal. These data from Chalkingham in 2012 looked at propranolol versus nadolol versus metoprolol. And you can see that propranolol and nadolol decrease the symptom burden substantially more than metoprolol. A lot of physicians care for patients, cardiologists care for patients with multiple different diseases, hypertension, tachycardia, heart failure. And they feel very comfortable with metoprolol. And so it'll often be their first go-to antiarrhythmic agent for long QT syndrome or CPVT. And in fact, it's not the one you should go to. It should be propranolol or nadolol. There are, there are also data that suggest that mexiletine can reduce arrhythmic events in patients with long QT syndrome type 3. And sorry about this overlap here, ignore that. But mexiletine has been shown to shorten the QT interval and reduce cardiac events. And actually in type 2, in a small group of high-risk long QT syndrome type 2 patients, mexiletine significantly reduced the QT, as shown here, and decreased arrhythmia burden during follow-up. So mexiletine for type 3, more classically, and for some problematic type 2 patients. We do ask the patients to have certain lifestyle modifications. I think a really important one is avoiding QT prolonging drugs, avoiding and treating fever and hyperthermia. Sports can be allowed with appropriate counseling and the appropriate gear. And I still worry about swimming and diving alone as a patient's sport because of the risk of cold water, the risk of breath holding, and the risk of having a faint in the water, being an actual drowning or near drowning. What about future therapies for long QT syndrome, sort of out with the old and with the new? So beta blockers and the sympathetic denervation can prevent events. The ICD rescues patients, but these therapies really don't correct the problem. Some long QT syndrome patients are very difficult to manage with conventional therapy. Patients with calm mutations, patients with Timothy syndrome, those with Jervell-Lange-Nielsen. These patients are very problematic, and we'd love an additional form of therapy. Well, there are people looking at different forms of therapy, and what they're looking at is replacement gene therapy. It's a straightforward strategy in which expression of a defective gene is restored. So it's been looked at now in KCNQ1 variants. They often exhibit this dominant negative effect. Thus, replacement alone is insufficient because you just require so much expression to overcome the dominant negative. So researchers from the Mayo Clinic have looked at KCNQ1 suppression and then replacement gene therapy to overcome this problem with dominant negative effects. And interestingly, if you do this, it targets the entire gene, not just an individual's specific mutation or variant. So KCNQ1 suppression replacement therapy is theoretically applicable not just to LQT1, but maybe Jervell-Lange-Nielsen, which is often 2 LQT1 genes. So these are data from the group, as I mentioned, from Dr. Ackerman's group, looking at suppression replacement KCNQ1 gene therapy for LQT1. So a KCNQ1 short hairpin RNA is used to suppress endogenous or the person's expression of the gene. And then a codon-altered short hairpin RNA, immune copy of KCNQ1 is added back. A normal copy is added back. So this is shown to rescue the prolonged action potential duration when used in induced pluripotent stem cell model cardiomyocytes from 4 patients. So they derived stem cells from four patients with 4 different LQT1 causative variants, and they studied those. And the suppression replacement therapy shortened the action potential in this population. And this is, in fact, the first proof of concept preclinical study for hybrid gene therapy, both suppression and replacement in LQT1, and is capable of providing complete rescue of the KCNQ1 function. Applicable to all patients because it targets the whole gene rather than specific variants. And I think this is very exciting and something that keep an eye out on the horizon for what will happen with this. So in conclusion, most channelopathy patients are well covered by conventional therapy, drugs to denervation to devices, but problematic patients exist. And conventional therapies may not always be well tolerated. So many patients, I think, would consider other strategies if they proved safe and if they existed. And they are emerging and will likely make patient management either easier or more effective or both. So thank you. I'm going to try to stop gene therapy.
Thank you so much, Susan. And we have 10 questions posted here now. So let's get started with those.
Can you get rid of this share? I'm having trouble getting.
Oh, sure. hit stop
Oh,
share.
stop share. Got it.
There you
Okay.
go. All right.
Thank you.
Okay, first question. What is typically done when a patient is on maximum dosage of flecainide and still has PVCs?
Excellent question. I would assume also beta blockers, since flecainide is usually our second line therapy. And I would make sure that it is only PVCs. And it probably depends on the phenotype of the patient. If that patient came to me having had a cardiac arrest, and now we're still seeing PVCs, that's a very different patient from a patient who I saw because of a family history of CPVT, who's now having PVCs. The cardiac arrest patient, definitively, in my mind, somebody who has had those egregious of symptoms with CPVT probably requires triple therapy, and I would do a sympathetic denervation. Or actually, I usually send my patients to Dr. Ackerman for their group to do a sympathetic denervation. If it's a patient with PVCs only, and they only presented with the genetic abnormality, not an event, I would be a little bit more cautious about moving forward with the sympathetic denervation. I would make sure that PVCs are all they have, and I probably would put a Holter on them to make sure they're not having episodes of arrhythmia that are related to different adrenergic stimulus. And I would make sure the flecainide level is adequate, because people metabolize drugs differently, and flecainide is likely one of those drugs. And I can tolerate a few PVCs. Excellent question.
Okay. Next question has 3 votes. I sure would love to see a list of names of heart meds next to the symptoms they provide relief for.
Oh.
Is there something like that for someone in the early stages of symptomatic ARVC?
Ooh, probably. Probably in categories, like classes. We classify antiarrhythmic medications into class 1, class 2, and class 3, with 1 being things like flecainide and what they are used for, and then beta blockers and what they're used for, and calcium channel blockers and what they're used for. And that is an excellent question, because not every patient responds to every medication in the same way, probably related to our pharmacogenomic background and the things inside of us, our genome, that metabolize drugs differently. So some beta blockers are totally ineffective in some people, and others are too effective, and they get too bradycardic and hypotensive. So there are probably those tables. They're probably hard to come by, but I would look into the Vaughan classification to see that data.
Okay, thank you. If beta blockers have a tendency to trigger electric storms in certain people, like in Brugada patients, would having denervation surgery make things worse, or rather, what would be the benefit?
I'm not sure that in Brugada syndrome, it's been tested for just the reasons that you asked. It isn't my first, it certainly wouldn't be a go-to that I thought of in Brugada syndrome. So probably something to be avoided, especially since you think about, if you're having a Brugada storm, the drug we use is isoproterenol, which is the opposite of a beta blocker. So very good question. One of the places where potentially a sympathetic denervation is not indicated.
Thank you. Have you seen any patients who had LCSD have side effects appear years later?
Not so far. Most of the patients that I have sent, and I've sent dozens for a cardiac sympathetic denervation, have acute side effects. I haven't had anybody have a ptosis, that droopy eye thing, by the time I see them. I think they might have it for a few hours occasionally post-operatively, but I haven't had anybody had anything but regression of symptoms over time. I think the slowest one in my mind to go away is the differential sweating of their hands, and occasionally the differential facial flushing when they're really, really exercising. And that's obviously more obvious in the super Caucasians like me compared to darker skinned people.
Okay, thank you. Who is on the cutting edge when it comes to performing ablation procedures with the most advanced devices and minimal complications?
Depends on what you're ablating. But if we're thinking about what I spoke about, it is Dr. Kuluani. I think he's in California. I've met him many times. Lovely human. Probably there are maybe a dozen throughout the country, but he's written the most on epicardial ablation in the setting of Brugada syndrome. But if you're getting ablations for other things, it's going to be other people. And probably most ablation has a lot of experts to care for those patients. It's just that Brugada syndrome is so rare, and ablating Brugada syndrome is even more rare, that you kind of want to focus it in a certain expert center.
Very good. What proportion of your patients experience arrhythmic storms that don't respond well to beta blockers like amiodarone or lidocaine, but do respond well to isoproterenol that you mentioned and overdrive pacing? You think this drug, isoproterenol, is typically available in hospitals across the country?
Good question. It is. It's a pretty old drug we've been using for a very long time. It's probably on the resuscitation cart at every hospital. It's a beta agonist. So unlike a beta blocker, it agonizes, or it helps the beta receptor, and you can sort of dial a dose. You dial it up till the heart rate you want. So yes, I have had to do this occasionally, not very often. Atrial pacing is also going to give you the same effect because you're going to increase the heart rate, but it's often not possible if you don't have a pacemaker or the ability to quickly place a pacemaker. It doesn't happen very often. Possibly it's because I'm in a population of children, and children don't have much Brugada syndrome. And those that do have Brugada syndrome typically are genetically positive and maybe not yet phenotypically or expressing the disease. So if you asked an adult cardiologist, they may have a very different thought about that. I have seen it in CPVT, and in those patients, you wouldn't use isoproterenol. You would use beta blocker. You would use esmolol. You would do everything you can to drop the adrenaline level in the patient, and it's pretty easy in CPVT to treat that. Not super easy, but pretty easy.
Okay, thank you. Some research has shown that long QT1 patients have reactive hyperglycemia and later a risk for developing diabetes. Is it necessary to follow some kind of low GI diet? And this was asked by Samantha.
Great question. And I think the data are still inconclusive. I certainly have seen hypoglycemia, not just in LQT1, but in LQT2 patients. I don't know how much of it is going to go on and cause or result in or be associated with diabetes, but it's a fascinating area of study. I don't know that because I typically see kids and they haven't yet gone on to develop diabetes. But where I see hypoglycemia are typically toddlers, because toddlers on beta blockers will take their beta blocker because their mom gives it to them and they're very used to it, but they may just decide not to eat that day, not at all. And so, or they're ill and having some vomiting disease. So they are at risk for hypoglycemia. And that's typically been the population that I've seen it in. And I do counsel my families to have a rescue source of sugar at home if they have a patient on a beta blocker. And I use cake icing, like that nasty stuff in the tube, because you can just squirt it under their mouth, under their tongue, and they absorb it. And I have patients where that has also been so problematic, we give them glucometers so they can check the kid's blood sugar.
Okay, thank you. If suppression replacement proves to be a success in ongoing trials on rabbits, do you think the treatment will be available to all long QT1, 2 patients, regardless of the severity? If so, how long do you think this will take?
This is really a very good question. Michael would be the person to ask it to. I think we'll start with long QT1 and problematic long QT2 patients. I think you're probably looking at a decade before it's out there for general consumption. Obviously, you start with the most symptomatic patients, the most problematic patients, and then eventually it expands to patients with more mild disease. But it is very exciting. And I think that there are a lot of people looking, finally, a lot of people looking at these orphan diseases like the channelopathies and the cardiomyopathies for different forms of therapy. Certainly, I've been tired of treating the symptoms rather than the disease my whole life.
Okay, another question from Erica. In the paper about CPVT and the impact of ANK2, published in May of 22, a patient also had a mutation of the CAC in A1C. What impact could a mutation in this gene have?
Oh, good question that I don't know the answer to. I'm just going to say I don't know.
Okay.
They're important genes, well, especially CAC and A1C. That's an important gene in calcium metabolism. I'm less certain about.
Okay. Let's see. A sympathectomy has been recommended for this person, told by their cardiothoracic surgeon that the trade-off is extreme sweating, flushed skin on one side of the face, among other side effects. They've been diagnosed with long QT, no genetic component, and survived a cardiac arrest last 2019. What are the, let's see here, fell off my screen. I guess what are the, oh, let's see here. What? It's trying to load the question onto my screen. Can't read it.
I can go through a little bit.
Long-term study effects, side effects.
Oh, actually the long-term side effects, as I said earlier, the side effects of having a sympathetic denervation just get less obvious over time. I think that the one thing I will say is be sure about the diagnosis. Be sure it's long QT1 because you are genetically negative, or be sure it's long QT syndrome at all because you are genetically negative. You would want to be certain about that. And number two, get it done someplace that does a lot of them, where they do a complete one and they do it videoscopically because you don't really want a whole sternal incision. And the recovery is certainly faster. It's usually just a night in the ICU and then a night in the hospital and then home. So get it done for the right reason and by the right person. That's precision medicine.
If a young woman with a history of generalized hypermobility syndrome, then unwitnessed fainting spells in college, has a cardiac arrest several years later after droperidol is administered in the ER to control vomiting before an abdominal CT scan and placement of an ICD. And the question is again hidden from my screen. It's loading. Let's see. Let me get some help from staff. What's the rest of that question?
Not going to be something I know a great deal about in terms of channelopathies. That hypermobility, like EDS or Marfan's, those are kind of different diseases than we're talking about today. And
here's the rest of the question. Okay. Was where do you begin, or how many genetic tests do you run to get the proper diagnosis and the medication treatment plan?
Obviously, it depends on the phenotype. Other than hypermobility, what's the echo look like? What does the EKG look like? You want to tailor your genetic testing to the patient's phenotype. So fainting, hypermobility, it's different than the diseases typically that we're talking about right now. So one would want to really characterize the phenotype and design the genetic test based on the phenotype.
Okay, thank you. Could a person who is SCN5A gene positive have a negative procainamide challenge, but years later develop Brugada syndrome? This came from Kelly.
Yes, Kelly. Excellent question. And in fact, there was a study years ago about doing a procainamide challenge at one stage in a child's life and then doing it again when they were a teenager. And some patients did change over time. I think this is a disease that the phenotype can change, obviously, since it presents typically in adults. And procainamide is not the perfect drug. I don't think it provokes Brugada syndrome in every single patient who actually has Brugada syndrome. So, ajmaline may be too good. Procainamide may be not good enough. I don't think we found the perfect drug for eliciting the Brugada pattern yet. And we don't have ajmaline in this country, only procainamide. So.
Okay, thank you. Okay, is it possible to have both monomorphic and polymorphic VT and CPVT patients? This came from Amy.
Yes, I think it's more classically polymorphic, but I think you can see monomorphic, and other times it's just sometimes hard to tell. But certainly the PVCs can be monomorphic and then progress to bidirectional or polymorphic over time or over a certain adrenaline level.
Okay, thank you. Ruth asks, is breastfeeding allowed in a 1 year and possible, let's say, wait a minute. Is breastfeeding allowed in a 1-year-old child if I'm advised to switch from beta blocker bisoprolol to sotalol? This came from Ruth, who's in Germany.
Oh, Andrew's here. I hope he knows more about those two beta blockers than I do. I typically let my patients taking Nadolol continue to breastfeed. Andrew, chime in if you know anything about sotalol and breastfeeding. I would worry, but I'm not sure it would be appropriate to worry.
Yeah, Dr. Etheridge, I'm not sure as well on that. It's a great question, though.
It is a great question. Yeah. Most of your obstetrician gynecologists can gather those data, though. And the amount that'll come through in breastfeeding is pretty minimal, but still you wouldn't want your child to get sotalol.
Okay.
Thanks, Andrew.
Okay. Yeah. How does bradycardia affect long QT and possible events? Should it be treated? Currently have an SICD and typically 3 to 50 beats per minute, frequently out of breath while exertion occurs. They're a sudden cardiac arrest survivor, long QT type 5. Let's see here.
I don't have data on 5. I have some data on 3. So the sodium channel mutations, long QT syndrome type 3, bradycardia and nighttime can be the time when events occur. And I have had success with pacing those patients and keeping heart rate regularity. I've had some success in the LQT2 population where pacing them at a 60 or 70 beats per minute help prevent events. Typically, these are patients with ICDs anyway, and so it's pretty easy to dial up or dial down on the heart rate. Unfortunately, with the SICD, you can't do that. You can't pace, so that is a somewhat of a disadvantage. I don't know about 5. I don't follow enough patients with long QT5 or even know the veracity of that gene at present.
Okay, thank you. Does the patient have to be in the Brugada pattern in order to ablate this? I go in and out of pattern, but had a positive EP study. How do we diagnose and treat patients who go in and out of the pattern? I'm mainly concerned about my children.
Correct. Excellent question. Actually, really excellent question. I'd have to ask Dr. Kulwani about when he takes them to the lab. I would assume because they're anesthetized and asleep and fairly bradycardic that might be the best time and they might have more chance of having it. I would also assume that the fractionated stuff is there, even though the pattern may not be. I would also wonder, I don't know that he's going to be taking patients with only intermittent Brugada pattern to the EP lab. Right now, it seems like they're taking for ablation only the most problematic patients for that study, for those data, that test.
Okay. So my EP took me off Nadolol due to my pregnancy and fetal growth restriction. I am asymptomatic long QT type 2 patient. Are the issues with Nadolol true?
I'm just going to tell you what I do. I leave all my Nadolol patients on Nadolol during pregnancy on the same dose that they started the pregnancy with, especially long QT2. There are pretty compelling data that patients who are not on beta blockers and have long QT2 do fine during the pregnancy, but peripartum need to be on a beta blocker. And I think sometimes starting a beta blocker after someone has just delivered a baby and have all the other life experiences that go along with delivering a baby, and you add to that a new beta blocker, I think that's a problematic situation. So I have had multiple patients stay on their beta blockers and deliver a fetus. They are a little bit smaller, but they have done generally pretty well. The other thing is your fetus affected? I mean, your child has a 50-50 chance of having that disease. And can that beta blocker, can the Natalol be helping the fetus? I think you're going to hear more about that later in the day.
Yes, we have another talk later. All right. I think that includes all the questions posted that I could see. All right.
wanna
Thank you
thank
very
you.
much, Susan.
Thank you. It was very fun and excellent questions, you guys. Really excellent.
All right. We appreciate your time.